thank you, as others have said, to Artie and Jack for inviting me down here, although a couple things. I got 2 strikes against me. I'm coming later in the day, and so a lot of what I'm covered has already been touched upon, but that's okay because we'll talk more about it. And I'm also coming right after lunch when everybody's looking for a nap, but I'll do the best I can. Okay, so what I'm going to try to do is talk a little bit about where we might think about using JAK inhibitors in spondyloarthritis. And it's a pretty broad topic, but I want to kind of highlight what we know about these agents, and then we'll talk more next from Kevin about some of the safety, which is a big issue here. These are my disclosures. A lot of that is data safety monitoring board work, which I actually do a lot of it with Kevin, actually. Why JAK inhibitors? So the truth is, these agents are not that new. We've been chasing small molecules in general, and kinase inhibitors in particular, for 20 years. Some of you may remember p38 inhibitors way back in the day that just never went anywhere, MAP kinase inhibitors, et cetera. And then, they're suddenly a big deal because there's a first class of kinase inhibitors that actually worked, or at least had a reasonable risk-benefit profile that made sense. The reason that they make sense in many ways is that there are a variety of cytokine pathways that drive these different diseases, and maybe targeting one cytokine isn't going to be the best approach, and maybe you actually get better mileage about targeting across cytokine pathways. And interestingly, although we think of tofacitinib and these newer agents as originally RA drugs, the very first clinical data for tofacitinib was actually in skin psoriasis. JAK inhibitors have a lot of potential. They're oral. I think we're used to parenterally administered drugs over the last 20 years because we've had to. We've had no other choices. But in a perfect world, an oral drug is much simpler. They have a really fast onset of action, faster than I think any of us really expected. You sort of think about a parenteral drug as going to be fast, and it's really amazing that an orally administered drug is actually faster in many cases in terms of when you first see benefit in the patients. The short half-life, on the one hand, means that you have to take them reasonably frequently, but on the other hand, it gives you some benefit if you get into issues. If you get into toxicity that you want to stop the drug. If you have a patient who's prepping for surgery and you say, I'd rather not have them on the drug at the time of surgery, you're not talking about a 4 to 6 week lead time, a week, and they're gone. Pregnancy, same thing. If you get a patient who's considering pregnancy and you're uncertain about whether you want to continue the drug, you don't have to wait 3 months like you would with methotrexate, for example. So that's huge. They're very well tolerated, remarkably well tolerated. Very few short-term side effects. Most of the toxicities that we think about are more longer-term toxicities, effects of these drugs. They target multiple signaling pathways, which can be good and bad because you hit the places you want to hit, but you may hit off-target effects. And they're inexpensive. I can't verify it, but in talking to some colleagues, what I understand is that currently generic JAK inhibitors is the drug of choice for RA in India because they're like $20 a month. It's like ridiculous because it's easy to make a generic drug, and we'll see what happens in another 2 years when tofacitinib goes off patent. Negatives. So we've gotten used to biologics and the idea that you don't have to do quite the kind of lab monitoring that we've done historically with the DMARDs that we use, whether it's methotrexate or leflunomide or all the other immunomodulatory drugs, but you do need to follow them with these drugs. You do need to watch cell counts. You do need to watch LFTs. You do need to watch renal function, lipid profiles, as we heard earlier, similar to what you see with tocilizumab. There's this odd increase in CK that doesn't seem to be clinically relevant, but it's something to pay attention to. Infection risk, as we've gotten to newer biologics in the spondyloarthritis space, we've seen lower risks of infections. Not the case here. We're back with some of the same risks that we've seen with TNF inhibitors in the past. We're not getting, not necessarily worse, but not better. Off-target effects, as I mentioned, that you can target where you want to, but these drugs, the kinases have tons of effects in the body, and they're in all kinds of cell types. And so off-target effects in cells that you don't think you're going after, like hepatocytes, for example, may be issues and something we need to watch about. We touched on the cardiovascular risk earlier. Is that because TNF inhibitors, as Jack alluded to, lower that risk? Is there potentially some independent risk here? We don't think so, but it's an issue that's out there, and I'll come back to that at the end of this. And then the other negative prescribing restrictions, because of the labeling, it's sometimes challenging to get these drugs earlier in the course of therapy when you might otherwise want to consider using them. I think it'll be fascinating in a couple years when generic tofacitinib becomes the cheapest option, whether we're going to be able to get to it early or not. All right, so what are they doing? Like all kinase inhibitors, the idea is they're working intracellularly. If you've got a cytokine driving signaling to some of the inflammatory cells that you're chasing, somehow that signal has to get from the cell surface down to the nucleus, turn on transcription of whatever important proteins that you think that an activated cell is going to make. And without getting into a ton of details, the JAKs sit on the surface, and through linking with STAT molecules, they send that signal down to the nucleus and activate transcription of a variety of different important pro-inflammatory proteins, okay? JAK inhibitors, JAKs, not inhibitors, the JAKs interestingly work as heterodimers for the most part. So there are typically two different JAK molecules near the surface. There are in some situations, as you see on the far right, homodimers with JAK2, but frequently they're heterodimers. And there are actually four JAK molecules. There's JAK1, there's JAK2, JAK3, and if anybody knows the reason why the fourth one is TYK2 and not JAK4, I would love to hear it. I've never been able to figure that out. It's not even TYK1, which is really bizarre, but for what it's worth. I would call your attention to the left side of this screen where you see IL-12 and IL-23, importantly. And that, if you come back to it and say, what's the rationale for JAK inhibitors in spondyloarthritis? That's probably the single biggest rationale, because that's a critical cytokine in these diseases, and that cytokine signals through the JAK-STAT pathway. What you don't see on this slide is TNF or IL-17. All right, so that there may be, so that's not the pathway. Interestingly, and I'll come back to that in the next slide, you do see IL-6, which theoretically should be relevant in psoriatic arthritis, but I don't think it is terribly much. And so here's the story, and this is this whole pathway that involves Th17 cells that initially we learned about as we started to break down psoriasis, but then clearly this is important in psoriatic arthritis and axial spondyloarthritis in general. And what you see is that IL-23 sits way upstream in this pathway. And so the idea of using a small molecule that blocks interleukin-23 signaling as at least one of its mechanisms has a ton of potential for what it might do in spondyloarthritis and these diseases in general. I would note that IL-6 sort of plays a role there in affecting Th17 cells, but it has not panned out as a particularly useful target in the spondyloarthritis in general. So you can't always hang your hat on some of these kind of pathways. All right, so let's talk a little bit about the data that we have to date on where these drugs work and when they work. So as I mentioned, the very earliest data with tofacitinib in this space in general was actually in skin psoriasis. And these were some of the first trial data from psoriasis, and you see PASI 75 on the left and on the right for two different trials. The takeaway from all of that was there was some benefit with both doses, and at the time they were doing BID. This was before the extended release formulation had come out. And 20 milligrams a day, 10 milligrams BID, which starts to get into way too much toxicity, was the dose that was clearly effective. And so this was never approved for psoriasis. And they never went back to do additional data. But that was the first data. Then they moved into psoriatic arthritis because there seemed to be some benefit, early idea of benefit in skin. And I won't go through all the details, but at the end of the day, even the lower dose, 5 milligrams BID, was sufficiently effective in psoriatic arthritis, at least for the joint disease, to have benefit. And in this first trial, these were patients who were demarked inadequate responders. And I'm not showing you the data, but on the bottom line there was some benefit in skin disease, kind of comparable to what was seen with adalimumab, a TNF inhibitor. But interestingly, in the trial in TNF inadequate responders, where there was reasonably good joint response, the skin response was actually no better than placebo statistically. And this is, I think, why tofacitinib never got a ton of traction even after approval for psoriatic arthritis, because of the perception that it's likely to come after the more conventional biologics, and if it's not going to work for skin disease, which is an issue for many of these patients, maybe it's not a particularly great tool. Just a mention of other JAK inhibitors out there, not going to be in the US. They've discontinued development of this in the US, but it's approved, I believe, in Japan, and I'm not sure where else. But this was another effective JAK inhibitor, and here's in psoriatic arthritis, and you can see a tremendous difference on the bottom left there between active drug and placebo. ACR 50 responses on the top left graph there are pretty dramatic, MDA. So would have been a nice idea, but it just never went forward in the US. What did go forward was upadacitinib, which was eventually approved in the US for psoriatic arthritis. And what's nice about this particular trial is they used adalimumab as an active comparator. It was not powered as a comparative trial with adalimumab, but at least having the active comparator in there gives you a sense of the benefit of upadacitinib compared to a drug we use a lot for psoriatic arthritis. And so if you look on the top left there, at 12 weeks, the ACR 20 responses with upadacitinib at both the 15 milligram a day dose, which is the commercially used dose now, or 30 milligrams a day, which is what our GI colleagues are beginning to use for inflammatory bowel disease, both were quite effective for psoriatic arthritis, similar to adalimumab. And there was not enough of a difference between the two doses that it made sense to go ahead with the higher dose in psoriatic arthritis, same in rheumatoid arthritis, because with a higher dose comes more issues in terms of toxicity and adverse effects. And then on the bottom left there, you see skin responses that not the same as what you see with an interleukin 17 or an interleukin 23 inhibitor, but at least respectable. And for many of the patients that we see whose primary issue, and you heard some of this before, it's like, how do you make decisions on treatment, whose primary issue is joint disease, adalimumab is more than adequate to manage the skin disease in those folks, and upadacitinib was really pretty comparable to adalimumab in this trial. So this is patients who are biologic naive, who'd failed a non-biologic DMARD with the adalimumab comparator, and then the other trial they did was in patients who'd failed a biologic DMARD, mostly TNF inhibitor, some IL-17. There was no adalimumab comparator here because they'd already failed the biologic, so that it didn't make sense to add that into the trial design. But again, you see clinical responses in both joint response there on the left and in skin response there down on the bottom left, and all of the other domains of disease activity, including enthesitis and dactylitis. So there was value here, and there was a lot of excitement about this as an option in psoriatic arthritis, as an oral option that was every bit as good as a parenterally administered drug, until all of the noise came down after the oral surveillance study, which kind of put a wrench in the works. You heard about this drug before. This is a JAK inhibitor, deucravacitinib. It's a specific TYK2 inhibitor, which, as I said, is the fourth member of the JAK family. I think April showed you some of this already, but this is the two different large phase 3 trials with deucravacitinib in skin psoriasis. They used apremilast as a comparator, and I think it's pretty instructive that if you look at all the different outcomes from PASI 75 to DLQI, which is a quality of life index, it was effectively twice as good as apremilast across all the outcomes that they measured for skin disease. This is what we know about joint disease with deucravacitinib. There's a phase 3 trial going on as we speak, and I think it's likely to prove positive. But this is from the phase 2 study, which showed that deucravacitinib at the kind of doses that we're looking at and the kind of doses approved for skin are effective in joint disease as well. So we'll see where that comes up. And I think the key issue here is going to end up being toxicity. Is the toxicity here the same as what we've seen with the other JAK inhibitors, and I'll come back to that in a little bit. All right, axial spondyloarthritis. So interestingly, the rationale kind of makes sense, but not entirely, because it's in the same family, and yet we don't think of IL-23 inhibition, which is the cytokine we know signals through this pathway, to be that effective in axial spondyloarthritis, and yet these drugs are. Tofacitinib, so this was the data we saw with tofacitinib a couple years ago. Really interesting, because this was they explored this early on, quite a few years back, and then sort of dropped the drug until there was a lot of noise about, hey, JAK inhibition actually works in axSpA, so the company came back and went into a much larger trial to get approval in this case, ankylosing spondylitis. And again, without going into all the details, you see an ASAS-20 on the top and an ASAS-40 on the bottom, and you can see the pretty marked difference between active drug and placebo with response, again, very quickly. I mean, you start to see improvement within 2 weeks, which is pretty remarkable for an oral agent. Upadacitinib, this was from the early trial in AS. They developed this as a phase 2-3 trial. They used ASAS-40, 40% improvement as the primary endpoint. You see that over on the left. And then what you see on the right is MRI improvement, which I think is really helpful in these trials because it shows you biologic effect of the drug. Because what you're seeing on the MRI is reduction in bone marrow edema, which is effectively inflammation in and around the joints, both in the spine and at the sacroiliac joints. So this was the early data, the first data in AS. They went on and did a couple other trials. So the first one was the Select Axis 1, which was also an AS, ankylosing spondylitis. Hold that thought, because I'm going to come back tomorrow and talk a little bit more about non-radiographic disease in AS and terminology. But this at the time, we're not allowed to say AS anymore, but we'll come back to that. At the time, this was ankylosing spondylitis, and pretty dramatic improvement if you look there on the left in the first 14 weeks, which was the primary endpoint of the study. There's a lot of lines here because it has to do with whether they use an as observed analysis or non-responder imputation, but sustained response over time, again with that 15 milligram dose, the lower dose that was effective in both psoriatic arthritis and RA. And this is pure AS without biologics, so after failing an NSAID. Then the next trial, which was kind of odd, I never quite understood the protocol design, but in a single protocol, they actually had 2 trials run concurrently. One was in non-radiographic axial spondyloarthritis, so people who had axial spondyloarthritis but didn't meet New York criteria for AS, and the second was in AS in TNF non-responders. They were done separately, so they were 2 different trials, but run on the same protocol, so it all sort of falls under this Select Axis too. So here's the AS folks, and you see on the left an ASAS-40 response, which was the primary endpoint, and again, quite a difference between active drug and placebo that you really start to see within the first month. And then using the ASDAS, which involves an acute phase reactant, you can really see the difference between the 2 arms. So effective here. And then this is the data from the non-radiographic axSpA trial, the first data for non-radiographic axial spondyloarthritis with a JAK inhibitor. These patients got either placebo or the same 15 milligram dose. You see the clinical response on the top right, a variety of other secondary endpoints, including function, including metrology, which is movement that they didn't really see early on. And then you see in the non-radiographic axSpA group down on the bottom left there, the MRI data. Again, that same data showing biologic effect of the drug in this population as well. Not showing that it's slowing progression, not showing that it's slowing radiographic damage, but just showing that you have biologic effect on the joints and in the bones. All right, so that's the data that shows these drugs work. What are the potential pitfalls? Well, there are a number of toxicities that we've been chasing down since the JAK inhibitors have started to land in our court. Zoster, very clear, very early on. There's something unique about JAK inhibitors. In all the clinical trials, you see an increase of risk of zoster. Not dramatic, but it's there and it's consistent across trials irrespective of the drug. There was some question about filgotinib, which we'll never have, about whether it was slightly lower there, but for the others, it's all been pretty much the same, and it means that when you can, it's appropriate to vaccinate these folks either before or as they start drug, okay? The two big questions, actually three big questions, VTEs, MACE events, and malignancies. And then Kevin's going to talk about safety, but this has come up all along. Even before we had the oral surveillance trial, the question of venous thromboembolic events came up during the evaluation of baricitinib in RA. It showed up in one trial, it hasn't showed up in other trials. It's not been consistent across trials. It has not shown up as a clear-cut risk factor in upadacitinib trials. But it's out there, and it's something we have to be aware of, and certainly there's enough concern about it that it's something worth thinking about. MACE events, cardiovascular events, major cardiovascular endpoints. Again, is it specific to these drugs causing a problem, or is it because TNF inhibitors prevent that problem in the oral surveillance study? I don't know that we know for sure, but my sense is the same as Jack's, is that we're looking at these drugs are not as good at preventing those issues. The malignancy issue is kind of interesting, and I'll come back to that in a second. But what was fascinating in the oral surveillance study was that they did see a signal of malignancy, and it was in the same population had the signal of cardiovascular disease, which suggests that they may share a lot of risk factors in common potentially. I mentioned the lab abnormalities before. I don't think that these are a deal breaker, but they do mean that you do need to monitor these patients. And just as we've gotten used to with methotrexate or leflunomide or azathioprine or MMF in all of our patients, regular monitoring of lab work to pick up abnormalities early rather than later is going to be important. And the million-dollar question is, are TYK2 inhibitors going to be different? Because again, because of the way these agents work, different molecules signal through different JAK pathways, different JAK-STAT pathways. And we do know, for example, that IL-23 inhibitors are associated with fewer infections than TNF inhibitors. And that's pretty consistent across the trials, across different diseases. And so is IL-23 signaling going to be less of an issue in terms of toxicity with some of these drugs? Maybe. I think it was fascinating that when deucravacitinib was approved by the FDA for skin disease, for skin psoriasis, the FDA did not impose the same labeling restrictions on it that are across the rest of the JAK class after the oral surveillance study. So following the oral surveillance study, they updated the labeling for both upadacitinib and baricitinib, even though there wasn't the same data, but the FDA said this is a class effect potentially. Put that in the labeling, the wording is a little bit different. That same wording is not in the deucravacitinib labeling. Now, when the phase 3 trial comes to the agency for psoriatic arthritis, whether they're going to think differently in our space than they did in psoriasis, we'll find out when the time comes. And again, Kevin's going to talk about safety, but I just wanted to point out, and I think this had come up earlier, in the RA story in terms of the question of safety of these drugs. And without getting into all the details, if you look at the red bars on these charts, this was a reanalysis of all the tofacitinib trials in psoriasis and psoriatic arthritis using the same kind of risk stratification that people have gone back and done on the oral surveillance study. And what they found is the risk of cardiovascular events and the risk of malignancy is higher in the patients who have a known history of cardiovascular disease or high-risk cardiovascular disease. And there really isn't an increased risk in the patients with low risk or moderate risk, the younger patients. So I think these drugs have gotten painted with a really strong brush that suggests this risk is there, and I think we can do some risk stratification in our patients as we think about it. A couple other things to think about in terms of JAK inhibitors. Alexis touched on this, the comorbidities that come up in psoriatic arthritis, and how does that play in here? Well, we know that JAK inhibitors work in inflammatory bowel disease, although at a much higher dose. So the dose in Crohn's, they start at 45 milligrams, which to us seems sort of crazy. It's triple the dose we use, and then down to 30 milligrams. They do seem to work in psoriasis, as I showed you in that trial. Uveitis is a bit of an unknown. There's really no good data yet. There's some case reports, there's some anecdotal reports that suggest that it may be beneficial, but I think time will tell. You know, in our biologic space, we have a sense that IL-17 inhibitors are not as effective for uveitis as the TNF inhibitors. Where these drugs are going to fit in, I just don't think we have enough data to know that yet. We talked about the other comorbidities, and once again, in this space are the TYK2 inhibitors, and we have the first one, but there are others in development. Are they going to be any different with respect to some of these issues? We don't know that yet. Last thing I want to touch on, and I'll go back to psoriatic arthritis, is the whole idea of different domains of disease. And Alexis touched on this, and she had a little bit different graph, but it's the same idea, that there are people with bad skin disease, people with bad joint disease, people whose disease is both, and how do you pick a drug when you're trying to address which manifestations of disease are relevant in that particular patient? And again, you've seen this slide before, but this is the GRAPPA treatment recommendations, and I only put this up to highlight that JAK inhibitors have now landed in this recommendation, and where they landed is pretty much in the same space as IL-17 and TNF inhibitors across the board. So you see there on the left for peripheral arthritis, for axial disease, for enthesitis, for dactylitis, and even for psoriasis, they're sort of in the same ballpark as the biologics we're already using. Uncertain for nail disease, but the problem is I don't think we know what works for nail disease in these patients, and I think that's a challenge in general. And then for Crohn's disease and inflammatory bowel disease, the most recent recommendation said conditional recommendation. I think with the further data, the next iteration will probably put this in a strong recommendation given the data that we know we have for the use of hepatocitinib in inflammatory bowel disease. And then uveitis, as I said, it's not on the list because we just don't know. There's no data. All right, so to wrap it up, why would we use JAK inhibitors? They're effective in skin psoriasis, not as, at least tofacitinib, not as effective as some of the other agents we've got, but also effective in psoriatic arthritis, peripheral arthritis and psoriatic arthritis, and axial disease. The joint efficacy across the board in all these diseases is pretty comparable to what we've seen with TNF inhibitors and IL-17 inhibitors. Not so much with the skin efficacy, although that may change as we learn more about the TYK2 specific inhibitors. Multiple domains, as I mentioned, oral, which a lot of patients would prefer if we can do it. Safety profile seems pretty reasonable, particularly the short-term side effects are almost non-existent with these drugs. And in someone who's at low risk for cardiovascular disease, I don't think that issue needs to come up that much. And then the last piece, as I said, and I keep coming back to this, is it's a JAK, but is it going to be different? We'll see as time goes on. Thanks.